What medications are best for patients who experience intractable nausea and vomiting? Are there non-medical or surgical options to help with the symptoms? Is it okay to use more than one medication to treat nausea?
Join us as we discuss these questions and more on this episode of Medical Timeout. Welcome to Medical Timeout, a podcast where we discuss all things palliative care. I'm Rashmi Kadilkar.
And I'm Chinlin Ching. Over the next few episodes, we'll discuss complex symptom management in serious illness and at the end of life. We've already discussed pain and dyspnea. Today, we'll focus on intractable nausea and vomiting. In the coming weeks, we'll talk about delirium, as well as complex pain management and principles of intensive and aggressive symptom management at the end of life.
So let's start with the case. Mr. M is a 45-year-old with metastatic melanoma who was admitted to the hospital with intractable nausea, vomiting, and an unsteady gait. An MRI of his brain shows a new large brain metastasis with associated swelling.
I think anyone who's ever had nausea and vomiting will say it's a gross feeling. Nausea is another incredibly common and debilitating symptom that we need to address in patients with serious illness. About 80% of patients with cancer experience nausea and vomiting, and it's also associated with things like CHF, end-stage renal disease, and end-stage liver disease. So nausea is extremely distressing, feels awful, like I said, it's gross. It also results in other things that might affect people as a whole. So it might decrease appetite. It might make them not take in their medications. Hence, they'll lose weight. They'll decrease their functional status. And a lot of times they might decrease their ability to interact with other people as well. Patients describe nausea in many ways. They might just straight up and name it, I'm nauseous. They may also feel like they need to throw up, or they feel queasy. Some patients complain of something like heartburn. Others say they just don't feel right. As care providers, we might actually see them retching or throwing up or hiccuping. And patients who have nausea often are very still. And so they either sit or lie very still and with their eyes closed.
So it's obviously an incredibly distressing symptom. And so let's talk about some ways to manage it. So as we discussed in our dyspnea episode, there are multiple layers to managing any symptom, and that includes nausea. So we want to think about the treatment of any underlying causes. We want to talk about non-pharmacologic measures that we can take, and then we can also talk about medications to treat the symptom. So what are the causes of nausea? So, of course, nausea we think of as a GI or a gastrointestinal symptom, but it's actually mediated through the vomiting center in the brain. So the vomiting center, in turn, gets its inputs from pressure receptors and chemical receptors in the gut and elsewhere. So the nausea associated with something like cancer can be the result of a mass or an obstruction in the GI tract. It can be because of increased intracranial pressure because of brain metastases, or it can be because of metabolic changes like hypercalcemia. Nausea in people with cancer can also be caused by chemotherapy itself. People who have things like congestive heart failure, end-stage renal disease, end-stage liver disease might also have gastrointestinal distension and irritation. They can also have metabolic derangements that can cause nausea. And constipation can cause nausea. And many medications can cause nausea. So identifying a reversible cause of nausea can help to tailor the treatment. So, for example, if somebody has a bowel obstruction, relieving that bowel obstruction, whether that's with nasogastric decompression, whether that's through surgery and surgical decompression, can be a very durable treatment for somebody who has nausea from an obstruction. Resection or corticosteroids can help when somebody has a mass in the brain or a mass really anywhere. Steroids can also help with the associated edema that surrounds a mass. When somebody has something like liver disease and diaphragm irritation related to ascites, paracentesis to drain that ascites can be very helpful. And then Addressing metabolic derangements like hypercalcemia with measures like IV fluids or medications or even sometimes dialysis helps to treat that underlying cause and to get at the symptom. And of course, as we always say, everything that I've just considered has to be considered within the patient's goals of care.
Right. So back to Mr. M. Before his current admission, he had already decided to think about transitioning to a more comfort-focused plan of care. And that's how he wants to move forward now. He understands that his nausea is likely related to his brain mass. He declines surgery, declines radiation. And so now you need to consider medication treatments for his nausea.
So one treatment tier is non-pharmacologic measures. So for our example, our patient could try smaller meals, perhaps more frequently, so that he's getting in some nutrition and some calories, but just not taking in large amounts all at once. We could help work with him to identify triggers, different foods, different smells, maybe even different things he sees in the environment that trigger his nausea. And we could help him figure out ways to limit these. On the other hand, some smells could actually be helpful in treating nausea. So there is some evidence that putting a small drop of peppermint oil on a little pad and having the patient inhale that, or even using isopropyl alcohol, like using those little tiny alcohol pads that are so ubiquitous in the hospital, can be very helpful in reducing the frequency of nausea in people who are getting chemotherapy. We should also be looking for and treating constipation, as I mentioned before, because this is a really common cause of nausea that I think gets overlooked. And the treatment of constipation can involve medications, but in this case, the medications are aimed at the underlying cause of constipation, not directly at the nausea, but still something very important to consider.
Chances are, though, at some point, Mr. M's going to need multiple medications to treat his intractable nausea and vomiting, right?
He probably will. Unfortunately, we have multiple classes of medications that we can use to treat nausea. The ones that we choose depend on what we think the cause of the nausea is. That being said, the medication that our team reaches for most frequently as first-line treatment for intractable nausea in the context of a serious illness is haloperidol.
But Rashmi, haloperidol is considered an antipsychotic. I'm using a mocking voice because this is what we hear all the time from our consultants. Why would we use an antipsychotic to treat nausea?
You are correct. We do normally associate haloperidol with psychiatric illnesses. But haloperidol is a dopamine agonist. So it works in that vomiting center in the brain that I mentioned earlier, and that's why it can be useful to treat nausea. Because of its central action, haloperidol is effective for many types of nausea, whether it's medication-induced, metabolic, or mechanical, like in bowel obstruction. So haloperidol, as we may know from our psych rotations, does have potential side effects like dystonia, extrapyramidal symptoms, and a prolonged QT. These side effects tend to be much more common when the drug is used in higher doses, like the doses that are given for psychosis. So in our practice, we will typically start with 0.5 milligrams, either oral or more commonly IV for somebody with intractable nausea and vomiting, every 4 to 6 hours around the clock. At these low doses, we actually don't need to check the QTC. We don't need to follow the QTC, and there isn't a very large concern for sedation. We do find that haloperidol, like many antiemetics, is more useful if we give it scheduled rather than on an as-needed basis, as long as that underlying cause is persistent for the nausea. And some clinicians actually use other antipsychotics like olanzapine or Zyprexa or prochlorperazine or compazine, similarly to haloperidol. So what you choose to treat nausea in this situation might depend on the prescribing patterns where you are and also what's readily available in your hospital and in your local pharmacies.
I definitely remember when we as a group started using haloperidol as first-line treatment for intractable nausea and vomiting, that the hospitalists thought we were crazy and our orders would actually be discontinued or changed because they thought it was an error. It's still, there are still providers who are uncomfortable with it. but it's so effective. And it is first line for a reason. I also remember in training that I honestly would only use 2 medications, right? I used ondansetron or Zofran, and I used promethazine or Phenergan for everyone, regardless of the cause. Now I rarely ever use either of those medications because of the mechanisms of action. I understand them now. And it does not help for most causes of nausea. So, and these medications can be deliriogenic, especially Phenergan or promethazine. Ondansetron or Zofran has a very special niche for nausea related only to chemotherapy. So 4 milligrams PO or IV every 6 to 8 hours is a reasonable starting dose for ondansetron, but really use it for people who are nauseous from chemotherapy and not much else.
Now, some people have nausea that's related to something like a bowel obstruction, and these patients can actually benefit from corticosteroids like dexamethasone, and that, again, reduces inflammation and swelling in and around the intestines and around that obstruction. Because of how they work, steroids can help with nausea for brain metastases as well. So I would have a low threshold to add steroids for people whose nausea isn't improving with medicines like haloperidol and maybe ondansetron as well, provided that they're not receiving active cancer treatments or have other conditions that might cause or worsen with immunosuppression. So if I'm using dexamethasone, I will typically start with 4 milligrams, either oral or IV, once or twice a day.
That's a good starting dose. And the last class of medications that we lean on to help treat intractable nausea and vomiting is actually benzodiazepines. We don't really know the mechanism of action, but it actually works really well. I mean, if you think about how you feel when you are nauseous, you're very anxious. Again, it doesn't feel good. It can cause some anxiety. And so one of the inputs into the brain's vomiting center comes from the brain itself. And anxiety can trigger this. And so benzodiazepines are useful usually as second or third line or an adjunct medication for other medications, not standalone. I would usually start lorazepam at, again, 0.5 milligram dose every 4 to 6 hours, as needed in this case, scheduled if it is really severe.
And I wanted to highlight just a few more medications that we would use for specific causes of nausea. So people who have gastric dysmotility, like in diabetic gastroparesis, might benefit from a prokinetic agent like metoclopramide or Reglan. This is actually the one when I was in training that we used most commonly. That was number 1, and number 2 was ondansetron. And like you, I know better now. But for people who have this dysmotility, metoclopramide can be very helpful. It's important to remember that if these people also have some kind of a bowel obstruction, these agents can be dangerous. They can lead to painful cramping as the bowel contracts against an obstruction. They can actually lead to bowel perforation if not used in the right patients. And finally, sometimes we use antihistamines. So you mentioned promethazine or Phenergan. Sometimes you can also use diphenhydramine or Benadryl. These are particularly useful for vestibular causes of nausea like motion sickness. So these medications do have anticholinergic properties. So they can cause things like delirium, falls, urinary retention, constipation, especially in older adults. So especially in older adults, these are medicines that are lower on my list as I consider medical treatments for nausea. And then finally, we just wanted to mention the use of medical marijuana for the treatment of nausea. This is becoming more and more common. We won't talk about it in detail now. We may do a future episode on this in a few weeks. Not everybody can certify patients for this agent, but in the Rochester area, there are multiple palliative care teams and others who can certify patients for medical marijuana. So if you have a patient you think might be appropriate, we encourage you to identify the resources that are available in your own community for this purpose. So Chinlin, to complete this discussion, can you talk about a few procedural interventions that can help with nausea?
Absolutely. So one common cause for intractable nausea and vomiting may actually be some sort of obstruction or physical thing that you can actually act on. So you could have some external compression causing an obstruction where something like a stent might be able to be placed to allow passage of food or stool, and that can be done by gastroenterologists. The most common cause that we can think of from a physical obstruction is something like a malignant bowel obstruction, in which case the first thing that we try to do is decompression of the gut with what we call a nasogastric tube or an NG tube. It's usually placed to suction, and it decompresses the gut so that, things aren't backing up and people are not constantly vomiting. The vomiting is because there's an obstruction downstream, and it has to go one way. And the NG tube is not comfortable. It's often painful, but I think less painful than constantly vomiting. Another possible procedure besides the NG tube is actual removal of the malignant obstruction if it's doable. Mm-hmm. So if there's a solitary point of transition on a scan and the patient is not high risk, then surgery might be an option to remove the obstruction, and the patient might either have a colostomy or a colectomy from that. Another less commonly known procedure that we tend to often in the palliative care world is actually what we call a venting G-tube. So a venting G-tube is a gastric tube similar to a PEG tube or a feeding tube that we place in people, but instead of using it as a source of artificial nutrition and feeding, we actually use it as a drain, so the other way out. There are negatives to a nasogastric tube besides being painful. It really ties people to the hospital. And so if someone really is nearing the end of life and they have a malignant obstruction that is not surgically operable or cannot be removed, and it's not resolving on its own, keeping a nasogastric tube in permanently is really not something that we consider a comfort measure, and a lot of people don't like it. Dying while you're constantly vomiting is also not something that we would ever want for our patients. So what the venting G-tube does is it actually takes place of the nasogastric tube. Interventional radiology, GI, or surgery can place a venting G-tube if there is an anatomic window to go into the stomach. It acts as a drain. It allows people to eat and drink very small amounts for comfort, which is a plus. And it might allow people to leave the hospital if they wish to receive end-of-life care outside the hospital. It's not possible to have an NG tube. There's no wall suction in people's homes. Mm-hmm. And so having a venting G tube will allow some sort of drainage and decompression and have the person leave the hospital to receive end-of-life care at home or somewhere else if they don't want to stay in the hospital. And that's really important. So we do lean on that in the palliative care world as an option, as a palliative intervention.
So let's go back to our patient, Mr. M, who has indicated that he would like a palliative and comfort-oriented approach to his care going forward. So he's clear that he doesn't want any surgery or radiation for his brain met. So he gets started on haloperidol, 0.5 milligrams IV every 6 hours around the clock, and also dexamethasone, 4 milligrams IV twice a day, since he's got the swelling associated with that brain metastasis. Over a few days, his brain swelling reduces and his symptoms get better, but he still has some mild nausea. So he gets the addition of scheduled lorazepam, 0.5 milligrams every 6 hours. And then what we've tried to do for him is to alternate the lorazepam and the haloperidol. Each one is scheduled every 6 hours. So the idea is that he would get one or the other every 3 hours as he progresses through the day. So he's on 3 lines of treatment for his intractable nausea and vomiting, but it turns out that this is just what he needs. This combination of steroids plus haloperidol plus lorazepam does the trick. We're able to transition him to oral forms of the same medications, and he's ultimately able to go home with hospice to spend his last days with his family.
I really like that stepwise layering approach to medications and timing them. And that shows really thoughtful prescribing, and it turns out that it worked really well for him. So let's review what we discussed today. Number one, intractable nausea and vomiting is a symptom that, in addition to pain, is extremely common, unfortunately, in patients with serious illness and can have profound impacts on quality of life. Number two, when managing symptoms, it's important to consider and treat any underlying causes as appropriate within the patient's goals of care. And some patients might benefit from procedures for their symptoms, such as a venting G tube for an unresectable malignant bowel obstruction. People suffer immensely from constant nausea and vomiting. This procedure, as I mentioned, is palliative in nature and can help people achieve goals of end-of-life care outside the hospital.
Next, haloperidol and other dopaminergic agents are a really good first line for nausea without a reversible cause or which is refractory to attempted reversal of causes. So it makes sense to dose the antiemetics around the clock until the underlying cause has improved, and then some people can tolerate a decrease to PRN or as needed dosing. And then finally, it's important to remember that medications like opioids or antiemetics can be used concurrently with other medications and with non-pharmacologic measures, and can often be continued through the end of life.
And now it's important for all of us to consider disparities that exist within our healthcare system. We're moving on to our segment on DEI issues. Should we be aware of DEI issues when it comes to treatment of nausea and vomiting?
Why, yes, we should. So we know that non-white patients are less likely to have their pain adequately assessed and treated. And it turns out that there are similar data for nausea. For one thing, unfortunately, Black, Latino, and Asian American patients are less likely to receive antiemetic prescriptions than are white patients. I just feel like a broken record. Our system just has to do a better job of providing more equitable care, across ethnic and racial groups. And, we haven't talked about this explicitly before, but also across the gender spectrum, the sexuality spectrum, the neurodiversity spectrum. We just have to do a better job of making sure that everybody has equitable access to these medications and measures that are essential to improve their quality of life.
Yes, we do sound like broken records. We do need to be better. Well, let's talk about our pet peeves. Perfect transition. The things that drive us crazy as it relates to today's topic. For me, it's not trying to understand the cause of nausea and vomiting and just blanketing everyone with Zofran and Phenergan. There are many, many different classes of medications that can help with nausea. Start by understanding the cause, dig a little deeper.
And then we talked about how there are people, who don't respond to trying to reverse their cause. They don't respond to other medications. And so a medicine like haloperidol can be so helpful. And so for me, a pet peeve is the aversion that so many people have to haloperidol. And I get it. Before I did my palliative care fellowship, I would have felt the same way. I thought that haloperidol was for psychosis and hallucinations and things like that. With more education and experience under my belt, now I find it really frustrating to know that I have something in my toolbox that could be so helpful, but there's pushback from sometimes patients, families, from my medical colleagues all around, so that this medication that works well doesn't get used. The flip side is that some people immediately or eventually come around to using haloperidol for their nausea, and it is so gratifying, to check on a patient later in the day or the next day who's been started on the medication and to find that they're just feeling so much better because of a relatively simple fix.
Yeah. We hope this helps you in your practice.
And in the meantime, we'd love to hear from you. Please send us questions, comments, or topic suggestions by emailing medical_timeout@urmc.rochester.edu. This podcast is supported by a grant from the System Transformation Fund through the Safety Net and Program Supports Office with UR Medicine. Thank you to Kevin McCormick and Nancy Scott for spearheading the grant and for their commitment to palliative care education. Thank you to Levi Ganji for the music, and a huge thanks to Genesee Valley Media and Nick for recording, editing, and producing the podcast. And thanks to you for taking this medical time out with us. We hope you'll join us next time when we'll talk about delirium. Have a great couple of weeks.